Hey, everybody, this is, believe it or not, episode 4 of Oncology Update, where we're really trying to get to, God, should we say it, the truth in oncology. There's so much going on out there. It's a complex business. There's a lot of really cool science. There's a lot of progress going on. We're affecting a lot of people's lives, including our own. So let's jump right in and see what's going on out there this week. I don't know if you saw this, but a guy named Craig Jordan died. If you don't know who Craig Jordan is, he actually worked here at Georgetown briefly. He invented tamoxifen. You think about the impact of understanding the estrogen receptor and being able to intervene on it and have an impact on people. Talk about somebody who's had an impact on a whole lot of lives. That is Craig Jordan, and his impact will always be felt, but as a human, we will miss having him around. Up here on Capitol Hill, kind of a bad day for colon cancer. We've been lobbying to try and get colon cancer as a set-aside in the DoD budget. Remember that breast cancer stuff that's in there. A couple of other cancers are in the DoD budget as a set-aside, but colon is not a set-aside. It's in the pot. You can do colon research with DoD funding, but we didn't get our set-aside, even though we are among the top 5 in terms of common and seriousness and cost and all of that. We think we should be in the DoD budget, but we didn't make it. Dr. Kim Rathmel, new director of the NCI, she's got a lot of work in front of her. Budget being slashed up there on the Hill, but there's this ARPA-H thing, which is this new kind of designated money for more, I don't know, inspirational research might be the right way to put it, whereas NIH is kind of incremental research that gets funded. ARPA-H is looking for that leap of research. And then I don't know if you saw this. This is kind of interesting. We'll have a little bit of a theme on this today, is that out in California, there are 400 residents who work for a Kaiser organization there, and they actually formally filed to unionize. And I want to think a little bit about unionization and practice and the like. And let's talk a little bit about the business of oncology. So there was a recent paper by Mike Milligan. It was actually one of the ASCO pubs, and it was looking at US oncology practice patterns. And just very briefly, what they showed is that there was an increase in number of oncologists by 14% over, say, 2015 to 2022, but a decrease in number of practices by 18%. Well, you can do the math on that one. What it means is that more and more practices are getting bigger and bigger. And in fact, here in Washington, D.C., I work for a 7,000 physician practice here in Washington, D.C. And our oncology team is all one big team, if you will, and work together. So we're working more and more for someone, and we're working in larger and larger groups. And what it sort of suggests to me is maybe we need to start thinking about unionizing. Now, I'm not trying to be some socialist, although I was in England when the Labour won their vote over there. Now, they know how to have an election. That was way cool. We should take a tune from them. They know how to have an election, but we still don't. But, you know, we are being asked more and more to follow guidelines, to basically be on the assembly line doing what we're expected to do, and less freedom. And I think the way that we will regain some of that independence is through collaborative sort of bargaining, if you will. And so I do think I see that trend increasing as more and more of us work for one individual or one company, if you will. Other news on the headlines is that a guy named Robert Ferris, very prominent runner of the UPMC Cancer Center, has just moved down to a great cancer center as well, down at UNC in North Carolina at Lindbergh Cancer Center. He's a great guy, and he's going to do very, very well wherever he is. But then it made me sort of think, well, what's happening up at UPMC? Because I think about that as being a great place. They turned out to have lost over the last year $200 million in unbalanced budget, if you will, and they had to let go 1,000 people. And so we understand that our business is indeed fragile. Makes me wonder if Dr. Ferris made the trip out of there knowing that things weren't going to be very good at UPMC for the while. But we do need to take care of each other in our business of oncology. What we're going to really drill down on today scientifically is a single paper. This is a breast cancer adjuvant paper published in JCO not too long ago. And the drug that was added to hormone therapy in a big randomized trial was abemaciclib. So Priya Rastogi was the principal investigator. The full manuscript is out there. And what this was the 5-year survival, the 5-year update of this group. So half got traditional hormone therapy for ER/PR positive, HER2 negative breast cancer, quote unquote, high risk breast cancer. I'm going to come back to that, versus the same group getting the same treatment plus 2 years of the CDK4/6 inhibitor abemaciclib, 5,600 patients. Think about what they call high risk over there in the breast cancer world. Well, the control arm of this patient population had a 90% 5-year progression-free survival. I mean, it's this huge number, right? They're all doing very, very well, even though high risk. And it's node positive, it's bad features on the tumor. So it is bad cancer, but they've already figured out so much now that most of those people are cured. And certainly at 5 years, it's a very high number of people who are doing well. But to try and make that even better, they added 2 years of abemaciclib. And this drug comes with diarrhea and neutropenia, sometimes severe, sometimes requiring dose modifications. Would you take it or not? Well, let's look at the data. Well, the data and the curves do show an improvement in distant relapse, okay, of about 7%, with a hazard ratio of 0.67, right around there. And by any study in my world, this would be a home run. And I think it was pretty positive in the breast cancer world too. But you could think of it a couple of different ways. Remember, already the vast majority of these patients were cured, or certainly disease-free, with just the hormone therapy that they were on. And so to add on this, you could say, well, you reduced the risk by a certain amount. The risk was already small, 7%, it's a small number. So if you treat 100 women for 2 years, you pick up a few. But then what this paper was all about was overall survival. And I'm going to try and show you that. You see that curve? That's the bottom curve there. That's overall survival. And of course, at 5 years, there was no difference in overall survival. And even though this paper does sort of engender changing the standard of care, you treat 100 women with this situation, you give a bunch of them side effects, there's cost, and in fact, you haven't changed the overall survival. And most of them were already okay, and you did bump it a little bit. How do you present that data to a patient? Do you use hazard ratios? Do you use, I treat 100 people, it only helps 1? Do you present overall survival and say it's not worth it? Or do you have sort of a risk avoidance for yourself where you don't want to have been wrong? You have a patient on the other side who's afraid and will do almost anything to get out of this, right? So they're willing to risk toxicity even for a very low percentage, or at least most people are. And so it's all aligned, the stars are aligned to add this medicine for everyone. And so we are really dramatically over-treating most of these people if we were to add this drug to everyone, because most of them didn't benefit, most of them don't need it. It's only a small proportion of the patients who really get benefit. So I think as we are presenting new science, or as we are presenting options to patients, we need to be aware of this. So what we did is we found a patient, happened to be walking around a golf course with him, who wanted to share his story of his decision-making, where he actually decided not to take additional treatment, risk a higher risk of relapse in order to keep his taste, to keep his saliva, and to keep his quality of life. So let's hear from him now. Just a few days ago, Zach David, who, as we were walking and talking and comparing life stories on a golf course, he was telling me about his recent experience with his own cancer, head and neck cancer, with radiation and chemo. And what he told me was a fascinating story. So I want Zach to do a brief introduction of himself and really tell us about the process and the decision making, and in particular, this one decision towards the end of his treatment that was a trade-off between quality of life and maybe survival. So Zach, thank you on such short notice for being willing to join us, but take it away. Give us a little blurb on who you are and what you've been through, and maybe a little bit more about that decision.
Sure, Dr. Marshall. Thank you very much for the opportunity to help in any way that I can. Zach David, was diagnosed with squamous cell cancer in my neck when I was 48 years old. I have 3 children. Obviously, a big shock to us. Otherwise, I seem very healthy. And then, the decision trees that you talked about, which process. I started off with a surgical removal of the tumor in my tonsil, and then they did a radical where they took out, I forget the name, Dr. Marshall, where they
Radical
took
neck
out,
dissection, I think they call it. Yeah.
that's right. They took out all of my lymph nodes where they thought I had gone on the side of my neck. I had to decide whether to get a feeding tube before we went through this process because the radiation was going to impact my swallowing. We ended up doing that. 7 weeks of radiation and 3 courses of cisplatin, which was a all-day event of hydration, cisplatin hydration. And by the end of my second cisplatin, I think it was about week 5.5, 6 of the radiation, I was fully dependent on the feeding tube, was being admitted into the emergency room because the cisplatin was reaching so much havoc, no taste, high fever. And I went to Dr. Deacon, who was my oncologist, and I said, do I have to take this last dose of cisplatin? He said, well, you don't have to. And actually, a lot of people don't get to that last dose. I said, well, what are my percentages of survival? He said, your survival rate goes from 96% to about 90%. My next question was my quality of life. Will I have a chance of more saliva? Will I have a chance to regain more taste? And all the side effects that go with that chemo. And we decided after he told me that my chances were 90% versus 96% to not go with that. And today I can taste a good wine. I can taste a cheeseburger versus no cheese, et cetera, et cetera.
That's a really great story and very helpful to our discussion today. So thank you for sharing. But when you think back on that, obviously you're in good shape, right? There's no evidence of the cancer returning. Do you sometimes have sort of chills, or what goes through your mind about that 6% that you were sort of willing to give up for the trade-offs that you mentioned?
The biggest thing that I think about was that I had advocates and I asked the question. And you're faced with so many different questions through this process without advocates and lots of people to speak to and ask about the decision points. Really, you won't know until you ask or are faced with these decisions. Obviously, everybody's a little bit different and everybody has a little different decision tree that they need to make.
If you hadn't asked Dr. Deacon about that, you would have gotten that last dose, right? He wasn't going to come forward. It's not natural. I'm not picking on John. I know him very well.
Yeah.
But we don't naturally come forward and say, do you want this trade-off? Right? It
No,
really
this was
from the
yeah.
patient.
Yeah, I mean, this treatment was recommended by lots of doctors, nationally, worldwide. So this was the prescribed treatment for my particular cancer.
Maybe one last thing, because a lot of docs, a lot of oncologists around the country and really around the world are watching this right now. So what would you tell us as a patient? What advice would you give us about communicating these kinds of issues to patients, these kinds of trade-offs to our patients who maybe not quite as good a self-advocate as you were?
That's a really hard question, but one thing that my doctor, Dr. Deacon, did, he took a lot of time with me, and just taking the time to slow down in your decision-making process and educate, which not everybody has that luxury, and talk to people. I think that would be my number one thing.
I love it. I love it. Zach, David, thank you so much for joining us as we discuss this really tricky subject of these trade-offs, decision-making, shared decision-making to optimize patients' outcomes. Zach, thanks a lot.
Thank you for having me, doctor.
Zach certainly has an interesting story where he made the decision to not do a dose of cisplatin in order to try and optimize his quality of life, even though he knew that there was about 6% delta, just like our women in our breast cancer study had, of having a relapse. He made that decision, and so far he is happy with it. But what I think we need to do is drill down with one of the world's experts on decision making. And so right now we're going to cut to an interview with Dr. Mark Lewis. We are very, very lucky today to be joined by Dr. Mark Lewis. He is the director of GI Oncology at Intermountain Healthcare in Murray, Utah, which is, I'm assuming, a place somewhere in Utah. He does a lot more out there, but he's really one of the key thought leaders in the world of decision making in oncology. And he comes at it from a couple of very important angles, both sides of the exam room, if you will. And it really takes that perspective to, I think, make us all better at what we do. And so with that, let me welcome Dr. Mark Lewis, and we're going to drill down on this concept of decision making. So Mark, thank you so much for joining us, and maybe just open this up a bit. What's your take on how we're communicating with patients, these complex decisions, these complex pro and cons for adding drugs, length of therapy, toxicity versus benefit? Where are we with that in your head?
Yeah, thank you so much, John, for having me. And this is a topic that's near and dear to my heart, both in professional practice and, as we might discuss a little bit, even in how I've made decisions about my own care as a patient. So I'll start by using an analogy. I love figurative language. And one of the things we're talking about here is how to communicate with patients. So one of my tools is analogies. So I think a pendulum has been swinging where on one extreme, we had sort of the old paradigm of paternalism. You or I would walk into a room with a white coat on, and we would sort of try to project confidence. I think sometimes that maybe became almost kind of overbearing or imposing. And, the idea there was that you and I have done this long enough that we know what we're doing, and we basically just prescribed to the patient what they were going to do. And then I think the pendulum has swung potentially a little bit too far all the way across the other pole, which I call a la carte oncology, which is the patient comes in to consult with you or me, and we basically give them a menu. And we say, would you like option A, B, or C? And I think the problem with that, while it does respect autonomy, to be very honest with you, it kind of abdicates our responsibility. Again, there's a reason people come to us. And I think somewhere between, sort of bravado and, complete abdication, I think there's a place where the patient wants to know our opinion or our recommendation. So what I do is I do like to present options, but I also feel like I'm not doing my due diligence for any given patient if I don't tell them at the end of the visit, hey, listen, this is what I'm going to recommend that you do. One tool I found really helpful is sort of trying to take the patient's pulse on an individual level as to their, not just their scientific literacy, and I don't mean that in a condescending way. You and I both know how easily we lapse into jargon and the alphabet soup of oncology, but even how they view risk, because I think a lot of what you and I do actually is we're trying to mitigate risk for people. And what I've learned over the years is just percentages might not, especially if we just say them verbally, might not have the same impact as, again, trying to figure out, what do numbers mean to a given person, or do they prefer visuals? And it's interesting, John, we're all products of our training. I did my fellowship at the Mayo Clinic. At the time I was training, there was a huge emphasis, as you might imagine, on how to cancel patients on adjuvant therapy. And, the two diseases that I think made the most impact on me were breast cancer and colon cancer. Now, breast cancer was interesting. At the time, there was a software tool available not just at Mayo, but elsewhere called Adjuvant Online. You may be familiar with it. And it was beautiful, especially for a fellow, because you could essentially sort of plug and play with a given patient's data, and you could show them in visual format the added benefit they would get from, say, endocrine therapy. And I know you're talking about abemaciclib, which is, a little bit different, but then endocrine therapy plus chemo, like if you maximize your odds of risk reduction, what was it worth? And I guess what struck me, John, was with those patients I was counseling, and again, it was at the very sort of outset of my oncology career, there are some patients who would incur literally any toxicity that you consented them for if it resulted, even theoretically, in a 1% greater chance of them being alive at 5 years. And so I had that perspective from my breast cancer population, and then I developed actually a completely different perspective from treating patients with colon cancer. So, I trained under some really wonderful GI oncologists, and the first day of my entire fellowship, one of them, who was a true expert in colon cancer, said to me, Mark, if you do nothing else as a practicing oncologist, whether you go into GI or you're doing general practice, I want you to respect oxaliplatin. And I know that you know why he said that, and I've certainly learned it over the years. So I think one of the great advances of the last several years in our field, John, meaning GI oncology, was the IDEA trial. I don't know if we'll ever see its like again. Almost immediately as I was sitting at ASCO hearing about it, I think it was the plenary session in 2018, if memory serves, I remember thinking, I can use this the day I get back to clinic. The question is, how am I going to relay these findings to my patients in a manner that really matters to them? So again, without getting too much into the weeds of that study, but you and I both know, and I'll just repeat for the audience here, really a fascinating trial, again, really looking, I think, at the risk benefit of oxaliplatin in particular. So looking at this huge internationally pooled group of about 12,000 patients with stage 3 colon cancer, looking essentially at what was the trade-off between 3 or 6 months of oxaliplatin containing chemo. And there was a lot more nuance to it, but what I came away with was, okay, the disease-free survival at 3 years, which was the primary endpoint, was actually roughly equivalent, depending on some risk stratification. And what I came away with was to tell patients, listen, for perhaps a 1% greater chance of being alive at 3 years without your colon cancer coming back, you're incurring triple the risk of neuropathy that I probably am not going to be able to reverse for you. When I put it that way, rather than just saying, oh, the 3-year DFS was 74 versus 75%, and especially when I put it into visual form, so I've started using pictograms rather than saying percentages, actually printing out a picture of 100 theoretical patients, usually coloring them and showing, okay, it's almost like a spot the difference. I literally do spot the difference. So on one side, I had like all the colors of the people if they did 3 months of oxaliplatin containing chemo. On the other graph, I had the one with 6 months, and I said, hey, spot the difference. And I had colored it pretty subtly, but if you looked carefully enough, you'd see that there was one extra person alive without their cancer having recurred at the 3-year mark on the 6 month.
But even with all that, we still see our colleagues feeling like, if the cancer came back, what if I had given you 3 more months, right?
Yeah.
Are you the 1%? And so this sort of regret avoidance pushes us, I think, to do more than, and in many of us, I mean, you take the time, which is valuable, you show in a clearer way what it is to a patient, but a lot of us don't either have that skill set or have that level of knowledge on an individual decision. And so they say, well, the NCCN guidelines say this, that's what I'm going to do, right?
Yeah.
And because you have to, it's the playbook, right?
Yes.
And so, we have to figure out a way for us as healthcare providers to increasingly be comfortable with the de-escalation concept and the trade-offs that come with it.
Yes. So 2 things there, John. Thank you. And you're giving me so much credit, and I'm really flattered. One is the concept or important notion you raised about time. So I agree with you. The greatest premium needs to be placed on the time that we have, especially face-to-face with our patients. I don't know how your practice works. I get an hour with new patients. I get 30 minutes with follow-ups. And that first hour, as you know, there's you want to be present, but there's a to-do list in your head, right? As the oncologist, you have to do X, Y, Z. And by the end of the visit, you're supposed to, lay out a treatment plan and explain the intent. And I think one of the things that's really tricky about, say, adjuvant therapy in particular is it's all risk reduction. There is no 100% foolproof guarantee that the cancer is not coming back. So in regards to the time aspect, I am actually a huge fan of, and I'm just throwing this out as a practical tip for our colleagues, I really like one aspect of the EMR, okay? The electronic medical record is largely a billing and compliance tool. I'm well aware of that. But the part I like, and I think it's available in most systems now, is the patient portal, where I can exchange information with them, almost like a secure email. And it's nice because it's asynchronous. Like they can send me a message at midnight, and I can answer at 5 in the morning when I'm prepping the next day's clinic. So we can have that almost immediate interaction. we can exchange information, and I can send them resources. I can send them pictures or articles that I think are helpful, whatever issue they're grappling with, especially if it's this one. And then the other thing I would tell you about, decision regret, it is 100% real. There have been times in my career where the weight of decision regret has been so crushing that frankly, I've had a crisis of confidence and said, oh my gosh, like,
Yep.
am I really cut out to do this? And, I think if any of us are honest with ourselves, like it's appropriate from time to time to sort of step back and sort of survey your own acumen. But frankly, John, and this is going to sound strange, to me, that 1% who recurred because I gave them 3 months versus 6 months, I see that a lot less often than the people I see who are struggling with, and I'll use the word very carefully, crippling grade 3 or above neuropathy because I gave them, quote, too much oxaliplatin. I have had so many of those people in my career, especially pre-2018 and pre-IDEA, that all those things that my attendings told me the first day of fellowship, they have absolutely, rung true in my head. I have given thousands of patients oxaliplatin, and I've given a substantial number of them, and it weighs on my conscience considerably, neuropathy that I sometimes wonder. I sometimes lay awake at night thinking, gosh, did I need to do that? So you're absolutely right. The decision regret, sort of very black and white, is, okay, did I affect mortality risk reduction? But the other decision regret is, first do no harm is a very difficult principle for an oncologist to follow. Like primum non nocere with the drugs that you and I are dispensing is very, very tricky indeed.
Well, those surgeons cut people open. Let's give it, they have to do that. Listen, we could go on all afternoon, but I want to really thank you for coming in and sharing your thoughts on this decision making and the complexity and some of the strategies that you've used to make it better for your patients. I couldn't agree more that we need to be voting what we would recommend to our patients more than we are today, and just put up with that decision regret, because it's us that know more in many ways than our patients. So Dr. Lewis, thank you so much for joining our program, if we want to go quite so fancy as that. And I can't wait to see you in person soon.
Likewise, John. Thank you so much for having me.
That's a wrap on episode 4. I hope together we are working to find not just the news in oncology, but deeper than that. What's the reality of what we do? What's the truth in our world? And once we get the truth, we'll all be better at what we do. See you next time.